Yeah, because the insurance policy covers even for PSMA PET by now, 2023. But here for PSA in India and Nepal, we are lacking for those.
I found out that in Australia they don't cover it in so well in the recurrent setting yet.
Yeah, in prime.
Yeah.
So thank you so much, Dr. Indranil Malik. We now have a panel discussion on imaging for bladder cancer, MRI versus PET-CT. And to moderate this session, I would like to call upon Dr. Keval Patel, who is a consultant uro-oncologist from Gujarat Cancer Research Institute, Ahmedabad. As panelists, I would like to call upon Dr. Kumar Kallur, who is the Director Molecular Imaging, HCG, Bangalore, and Dr. Palak Popat, who is Professor Radiology, TMH, Mumbai. May I remind the moderators and the panelists that you have 5 minutes allocated for each case and last 5 minutes for discussion. Please stick to the time. Thank you very much. And please respond to my bells then. Thank you.
Dr. Palak. Good morning. First of all, thank you all for joining today for this panel discussion on a very important topic on imaging for bladder cancer, MRI versus PET scan. I thank the organizers for inviting me to moderate the session. We have assembled two very fine and eminent consultants as panelists today. Dr. Palak Popat is the Professor of Radiology at the Tata Memorial Hospital, Mumbai. Dr. K.G. Kallur is the Director of Molecular Imaging at the HCG Hospitals, Bengaluru. I have disclosures to make. The case included in the presentation are hypothetical and are included purely for generation of discussion. The images, although are real, but are used as a representation and may not pertain to that case. So with that, let us start with our first case. A 65-year-old gentleman presented with complaints of painless hematuria associated with clots since 15 days. There were no comorbidities or significant past history, no significant findings on examination. Hemoglobin was normal, creatinine was 0.96. USG was suggestive of 4 papillary lesions arising from left lateral wall. The largest measured 3.5 by 3 centimeter in size. Now the patient presented to us with an MRI. I would like Dr. Palak
May I request the panelists to sit on this side so that you don't block the screen. Thank you.
They'll need mics also.
I'll give.
I'd like Dr. Palak to interpret these images for us.
Yeah, so what I'm seeing is a series of images. On the top side, we have the T2 weighted image on the left, the diffusion on the center, the ADC on the right, and then we have the post-contrast imaging. So the best diagnostic thing on the first look is by a T2 weighted image, which shows the anatomy the best. And as you said, yes, there are 4 lesions that are seen. From the left lateral wall anteriorly, there are 3 lesions. They seem to be confined to the bladder wall. There is 1 lesion which is posteriorly, posterolateral, along the 5 o'clock axis, I would say. So that looks like a sessile lesion on the T2 weighted image. If I'm looking at the diffusion, there is a stalk that I can see. So if I have a lesion with a stalk, I'm not, generally by and large, they are not involving the muscle wall. The anterior lesions seen are also not involving the muscle wall because the detrusor muscle is normal. However, just behind, posterior to that lesion that I described along the 5 o'clock axis, there is an interruption of the T2 layer. If I look at the diffusion and the ADC, that is also restricted. And on the post-contrast also, that muscle wall is showing some enhancement. So the interpretation would be, yes, about 3 to 4 lesions. 3 of them are not involving the bladder wall, but the 4th lesion, which does have a stalk, has an adjoining area with a focal invasion of the bladder wall, and I would call it Virats 4.
Okay. Now, suppose I'll talk to Dr. Palak. First, suppose this patient did not present with an MRI. What would be your preferred choice of investigation?
As a radiologist and sitting in that, I would still be MRI. But ultrasound is always done first. I mean, I wouldn't say
patient
MRI
presented with
first.
ultrasound.
Yeah.
Now, for staging investigation, I'm just asking.
So ultrasound, if it does not show any nodes, so I'm predicting that maybe it is hopefully a confined disease, then an MRI. If the ultrasound shows a lot of nodes, then a CT.
So you want to send a message that if in ultrasound there are no nodes, we'll go for a MRI, otherwise a CT.
Yes.
Okay. So, let us have some look at both the modalities. CT being is advantageous in the form of being very fast, cost effective. It can image upper tracts as well. The first line of investigations in all the guidelines for macroscopic hematuria, and it can also detect M stage. Whereas MRI also has some advantages in the form of being superior in soft tissue contrast, no radiation, and better for staging T1 versus T2. So the point is well taken, Dr. Palak. Now, if we take a look at the comparisons between the performance of both, the specificity and other things are same for both. There is slightly high sensitivity for muscle invasion, as Dr. Palak told in MRI. Although both could not detect as many lesions as flexible cystoscopy, but here the scenario is different. We are talking only when the sonography is showing the lesions. So now, if suppose I'll have one answer for each question. So if the patient is MRI has been ordered, what would be the technical specifications to be taken care of? Like 3T versus 3 Tesla versus 1.5 Tesla.
Literature says 3 Tesla is superior, but
Great.
we don't need to wait. Both are okay.
Okay. Multi-parametric or conventional?
Multi-parametric, definitely.
What would be the cutoff for labeling is at muscle invasion?
So cutoff is more like whether we have a objective kind of an approach. So if there is muscle wall invasion or not. So VIRADS 4 is invasion, 5 is beyond, 3 is equivocal.
Okay. And the timing of MRI?
Timing of MRI,
As in relation to TUR?
It's best to do it before TURBT, but I know that is not our practice. So.
Okay. So let us have a literature view on these points. Like a meta-analysis of 24 studies with almost 1,700 patients found very high sensitivity of 92% and specificity of 87% for MRI to predict muscle invasion. Specifically, 3 Tesla machines had higher specificity than 1.5 Tesla machines. Again, by adding 2 functional sequence, there was increase in both sensitivity and specificity. Now, as Dr. Palak told, VIRADS is a vesicle imaging reporting and data system. It is based on T2 sequence and either dynamic contrast enhancement or diffusion weighted imaging or ADC. It has scoring from 1 to 5 depending on the size, exophytic nature, presence or absence of stalk, and an inner layer. The pooled sensitivity and specificity of VIRADS for muscle invasion prediction is 83 and 90% in a recent meta-analysis. Now, regarding the cutoff, we have very good evidence for that, 2 meta-analyses here. Wu et al. In his meta-analysis stated that cutoff of more than 3 is used in cases where high risk of MIBC is present, namely recurrent lesions more than 3 centimeter size, higher T or grade, and concomitant CIS is present. Whereas Liu et al., they found out that more than 3 cutoff can be used in patient in whom we are planning for a TUR. Whereas if we are planning directly on the basis of imaging, I think that is very impractical in present day scenario. But if we are planning for a procedure without TUR, then more than 4 can be used as a cutoff. Now regarding timing, it's always better to do before TUR. If the patient comes after TUR, at least 8 weeks is to be proper diagnosis of muscle invasion. 8 weeks are to be passed. So now, again, the patient had, suppose CT, we did a TUR. Histopath suggested of high-grade TCC of bladder. Deep muscles were present, but they were free. Now, what would you suggest? Would you, suppose the patient had present with that CT, now would you suggest an MRI, or as a urologist, we always prefer second look TUR, but would you suggest MRI at this stage?
I'm sorry, but I didn't get. So the TUR
the patient
was
initially
done,
presented with CT, the same findings. We did a TUR, no nodes. We did a TUR, and then the biopsy muscle is there, but it's not muscle invasive. Muscle is present, but it is not muscle invasive.
So our
And high
practice
grade
does
TCC.
not include MRI at this point of time, because I don't know if as a urologist somebody would want to wait for about 6 to 8 weeks. Accuracy is a little compromised. Yes, we definitely can do. There are certain telltale features which are seen on a diffusion and a dynamic post contrast, which do help us to differentiate post-URPT changes versus disease. But our sensitivity, specificity, when we talk of 0.9 initially, definitely drops down. So it's a compromised imaging, may not be strongly recommended.
Okay. So a point is very well taken. Even we prefer second stage TUR. Now, suppose after second stage TUR, the patient undergoes, it's again non-muscle invasive bladder cancer. High grade, patient is started on induction BCG and maintenance. After 6 months of the therapy, he again comes with hematuria. Now, USG is suggestive of thickening of left lateral wall, the site where we did TUR. What would you suggest next? Would you prefer MRI at this stage? Or you still go for we always go for cystoscopy, but we would like to know from radiologist perspective.
So we would now we're looking at either BCG cystitis versus disease. Again, as I said, MRI does help here, but the definite answer is going to be on a cystoscopy and a TURBT. So if there is something, so I think cystoscopy rules over here. And if, however, when there is a repeat imaging or the cystoscopy was normal, the cytology is negative, and we are going to pass him off as a BCG cystitis, there may be some role of a surveillance where an MRI may step in, because he's going to have some changes and you're going to keep on long-term follow-up.
So if cytology is negative and in cystoscopy you don't find any tumor, then you say that you will, as a part of surveillance, you may suggest MRI.
Yes, because then when there are early changes, if your protocol is going to include cystoscopy always, then maybe it doesn't have a role. But sometimes if a non-invasive intersperse of a MRI versus this as an invasive, non-invasive tool needs to be done, we have baseline changes, and that is when it can, the change or an increase or a change in the findings can be picked up on a follow-up compared to his earlier imaging.
Okay, now let us have some literature review. So we have a prospective study here of 231 patients. The authors attempted to evaluate the role of multiparametric MRI as a tool to select cases amongst high-risk NMIBC for relook TUR. So in their findings, they found that the sensitivity and specificity at the initial before initial TUR was 91 and 91%. And after, before re-TUR also, the sensitivity and specificity of MRI was 85 and 93%, so almost same, slightly decrease in sensitivity. Still, they asserted that definite recommendations regarding violets and as a part of evaluation before re-TUR needs to be considered only after we get a good robust data and with a large number of patients. So that way, it's almost ruled out till according to the present evidence. Now, regarding what we say that the regarding post BCG or post inflammatory any procedure, TUR or infection, what is the role of an MRI? So T2 weighted is very non-specific, only 50% specificity is there. Well, the specificity is increased by diffusion weighted and dynamic contrast enhancement. But we should mind here that DWI and DCE will increase the detection of recurrent tumors, but whether that extrapolates to detection of and muscle invasion, it's still well known. So till that not known. So till then, we may not recommend it as a routine investigation in post BCG recurrence. So with that, we move on to our next case. Again, a 72-year-old male presented to OPD with painless hematuria since 10 days. Again, evaluated outside in the form of an MRI. So we have these images. I'm disturbing Dr. Palak again and again. Can you please interpret this process, Palak?
Right, so the series of the sequencing is the same, T2 diffusion, ADC, and then the post-contrast. So here there is a papillary frond-like lesion, intraluminal, intravesical. That's no-brainer, but there is a small interruption along the posterior wall. Now, we see a curved hypointense line which is showing us a bladder wall. So if I'm only seeing the T2, I'm not sure if there is inflammation which is outside the bladder with an intact bladder wall and the tumor inside. Of course, it is sessile and it is not pedunculated. There is no stalk. Coming to the diffusion, however, so if it was inflammation outside the bladder wall, so though I have an intact continued detrusor muscle line that I'm seeing, there is diffusion restriction in that area. So inflammation and edema does not show diffusion restriction. So this should be tumor involvement, perhaps some microscopic spread through which it has creeped outside. And on the post-contrast also it is showing enhancement. So post-contrast, even inflammation would have, T2, even inflammation would have. The catch over here is based on the diffusion like as in the earlier image. So this is extravesical infiltration. This would be a Virats 5.
Okay, so you want to say that this, because of on the base of diffusion, this may be an extra microscopic extravesical spread.
No, it is a definite extravesical spread
Okay.
on the Virats 5. What I'm just trying to highlight is if I see the T2-weighted image, I'm seeing the detrusor muscle so beautifully continuous between the tumor and the extravesical that inflammation, what I want to highlight is inflammation has the same signal intensity on T2 like the tumor. So I cannot, as you said, T2 has a 50% accuracy for detecting tumor. So that is where it falls low, because I could have misread it as inflammation. But diffusion restriction will be present in tumor and not in inflammation. So I say definite invasion.
Okay. So now is there a role of PET-CT at this stage, Dr. Kallur?
For T staging, we have no role because of the very avid uptake which urine activity is coming into the bladder. But as he suggested that there may be perivesical fat infiltration. There are few
5
studies
minutes
done,
left,
but it is technically very difficult to do, where we do acetate scan and we can inject, and in a doubtful area where she told only those areas we can definitely tell whether it is infiltrated or not. But it is not done routinely in entire country. We do occasionally in our center because I have that facility in our center. We have a cyclotron we produce, but very anecdotal cases only. It is not routinely done. Still, the onus of responsibility is with the radiologist for T stage.
Okay, so I
Dr.
take,
Keval, excuse me, you have just 4 minutes to wind up the session,
Okay.
which includes discussion and cases, everything. Thank you
okay,
very
so
much.
I think that it is not beneficial for T3, right? Now.